Good morning, everyone, and thank for the organization to invite me to present this topic, and particularly to Jean-Pierre and to Gaët and Gavazzi. So my disclosure interests just based here. And when I saw the title of this presentation, I was a little bit puzzled by the word regulation. We will see two sides of this regulation. The first one is down for the vaccine registration. And there are, in some way, for the manufacturers to have some guidelines, recommendation for the agencies. And you can see here with the result, we have guidelines that cover the quality, regulatory, non-clinical, and clinical aspect on the development of influenza vaccine, the requirement for authorization, clinical immunogenicity, vaccine effectiveness, and post-authorization pharmacovigilance requirements. And we naturally know that every year we have the recommendation for the strains that must be put inside the new vaccine. And at the end, we have a lot of different vaccines we can use in Europe, and that is the work of the national agencies and European medicine agencies. But the other side of my presentation is much more based on the recommendation, and by the way, the result is for the vaccinees. We have vaccine for the vaccinees, and it's what we will see now. I went back to the Council recommendation from 2009. And on this recommendation, the first thing I want to stress is that there were some recognition of the burden of the disease with the at-risk population. So there is a problem. What kind of action are proposed by the EC Council is that we have a concerted action to increase influenza vaccine coverage. So with some targets we have to obtain. And we naturally we need a strategy against an influenza pandemic. That is not the topic today, but we need that sort of project. Healthcare workers should be made aware of the particular danger faced by their more vulnerable patients. So the role of healthcare workers seems to be very important. And we have to gather specific and comparable data at national levels. We will see that is very difficult. And we have a very good tool because CDC we have the mission to provide technical and scientific expertise to the Commission and to the member states. So what are the recommendations? The member states are encouraged to adopt and implement national, regional, and local action plans or policies to reach these target levels. The aim and the mean to do that. We have to improve vaccination coverage among healthcare workers. We have to take into account the definition of older age groups. We have to measure the uptake in all risk groups. We have to foster education, training, and so on, and to report on implementation to this recommendation. So a huge work we have to do. So the objective of my presentation is to give a picture of this recommendation now, from 2009 until 2015, and to understand what could make some differences within the different countries. So we will see where we are. We will compare, and also what is behind the fact that we have a low uptake when this reason is not in the plan itself. So, as I say, we have to enter the ECDC, and thanks to this report to give me very recent data, I will show you now. It's on this last report. And we are in Venice, I just remind you that. So if we look at the national plan, 31 countries received a survey. We have had 30 answers in this survey. An app is adopted in 3. They update their plan in accordance with Council recommendation in 2. And an app is not formally developed, but there are policies. What is the difference between policies and app? What we have to see. And NAP is under development. Though already we have large differences within the different countries in Europe. What about the different recommendations? you have here the number of people, the number of countries, and the number of countries with the specific recommendation. You can see here that for this whole person, an old person can be after 50, 55, 65. So it's not the same threshold within the different countries in Europe. For the immunosuppressed patients, each country agrees with the fact we have to vaccine immunosuppressed patients. 24 for the healthcare workers, 19 for the obesity person. For the pregnancy, you can see here that 23 out of 30 recommend the vaccination, but 4 out of 30 only for at-risk pregnancy, when we know that pregnancy is by itself a risk. So we have to understand these discrepancies. For the babies, is one of my grandsons here. For the babies, there are different ages, and just a few countries propose the vaccination for the youngest. And for the comorbid condition, you can see here that roughly all the countries agree with the fact that we have to vaccine this at-risk population. So, what is the result? What are the uptake today? You have here the target given by the EU, WHO, and the first in the class are the UK countries. I don't know after the Brexit if we could have such data. And we have there some lower uptake and very low uptake. It's in all the risk groups, and 25 countries were able to give the vaccine uptake. If we look now at people under with chronic medical conditions, only 10 countries gave an answer. And again, UK is at the best place, followed by Netherlands, followed by France, very far, and Norway also very far. So big differences for the at-risk population with regard to the vaccine uptake. What about the pregnant woman? Only 8 countries give an answer, and you can see here, 4 of them, always UK, and other countries, very low vaccine coverage rate. What about healthcare workers? 16 countries answered, and you can see again, we have the same shape of this curve. But it is really precise in the report. It's very difficult to compare the uptake from one country to another one because the figure we have are not based on the same way, with the same mean. So the numerator are based on administrative databases or immunization register or specific survey. It's totally different. And it can be different from one year to another one in the same country. So very difficult to have a global view of this uptake. For this point that are stressed by the EC Council, to analyze the reason why some people didn't wish to receive vaccination, foster education, report on implementation of this recommendation, it was not in this report. So my first take-home message is that NAP is at the discretion of the state members. There is a relative consensus on the target population. The vaccine coverage rate is not always known, some low, and it's with very large variation from one country to another one. So we will now compare some plans and policy through European countries and impact on vaccination coverage rates, how they are performed, what are the role of funding, implementation, and education. So there are different major policy-making bodies with different roles and interests if we look at the relation in the different countries. There is a role of the government, the role of National Immunization Technical Advisory Group, NITAGs, the role also of the professional societies and the health system. All that can be different from one country to another one within the Europe countries. And for the role of the national immunization is to propose a national immunization policy which is based mainly on the evidence, the burden of the disease, etc., etc. And they have to do a synthesis with regard to all this knowledge and translate this evidence into recommendation. If we look at the NITAG resource in the different countries, you can see that in Europe, it's not the same thing. If you can check all the boxes, you are in dark blue. If you can't, you are in pale blue. And so you can see here that not all the countries in Europe are in dark blue. So there are differences between the different NITAGs in the different countries. But at the end, the recommendations are either routine universal use in a target population, and generally it's founded, we will see that further, and the use in individual patients, maybe, if they need some specific target or not. So I think my first idea was that the founding was something which was very important to explain some differences within the different countries. So more or less, all the countries have national health service funding. Just a few have an out-of-pocket funding, mainly for pregnant women, for clinical risk patient here, for some adults, but household contacts. But if we look at the different countries, it's not a problem of funding. It's paid either by the regional health service or the combination of several mechanisms, etc. So there is no clear relationship between the funding and the uptake. We can't say that. So we will look now at some policy implementation, either globally. We will take the example of UK and Netherlands and France. This paper performed by Patricia Blanc was based on a survey with questionnaires that were following 4 axes. The management of seasonal influenza vaccination in programs, the influence of healthcare workers, the role of information and communication, and the access to the vaccine. I just synthesized some of these results, and I choose the first in the class, the middle in the class, and the last in the class to see if there were some differences with them, which can be very well seen. As you can see here that there is no difference in the recommendation for all 65 plus in these chosen countries. Just in the Netherlands, the national objective is, and high risk is clearly defined, seems to. The CVR is monitored each year, except in Poland. Healthcare workers have objective to achieve in high-risk groups in 3 countries, and the objectives are not so clear in France, as I know. There are incentives which are different between UK and France also. It's not the same way of incentive. We'll see that after. The reimbursement is not clearly a problem. The patients received a letter for free for flu vaccine, and there were different campaigns that are given in the different countries. So in the conclusion of this study, Patricia Blanc said that the vaccination policies are mostly implemented in a set and not in a standalone element. It's an holistic view. We don't have just one way to do the job. And there are 2 important cases that the monitoring of vaccine uptake must be done. And probably, as always, the feedback must be very rapid and not so long to wait. And distributing personal letters or vouchers for free vaccination may be of particular importance, but maybe not only, what we will see now. This personages in a cartoon is the GP. The role of the GP is, in all these countries, very important. And when you look at his job, he must know the guidelines, vaccine characteristic, and effectiveness. He must provide medical advice on vaccination guidelines, answer specific questions from patients, a role with patient. He must send a written notification or self-call on information material, organize and implement the vaccination program, organization. And the practice should have a responsible for vaccine program. You have to design someone which is this year responsible of the vaccination program. Have a register, update the register, submit accurate data on the number of patients eligible, Anxious stockpile is enough. Follow people who do not respond. Collaborate with others. Have flexible opening hours. A marvelous work. But what do you have to do else? What else? And if I have some incentives, maybe it could hire. I have to think. So I ask myself, is the difference between UK and France maybe through the incentives that are given? But if you look at this paper, it's a review article, they say there are two typologies of countries, some with a very liberal view and some with more corporatist view. And for the liberal countries, the incentive seems to be more, GP are more enthusiastic to have incentive. It's not really the case for the other countries. They are okay, but that is the corporation that say, yes, we want to work with you, you have to give us something in return. It's not the same way of incentives that are given within the different countries. But the impact, it seems to be, I don't know for the UK, but it seems modest in the program impact. I will be interested to share that with the colleague from the UK. And it's also very difficult to define the impact for the corporatist groups. We will now see the plan flu in the UK and in France. I like this word, holistic prevention. So it's a global aspect. With a policy decision in relation with the flu season, oversight of supply, the programmatic, procurement and distribution of flu vaccine, oversight of vaccine supply and strategic reserve, delivery of vaccine program, monitoring and reporting of key indicators related to flu, including flu activity, vaccine uptake, and vaccine effectiveness. So we need a return to know what we are doing is in the right place or not. And the GP's role is very important in the UK, and you can see that it makes GP practices and other providers responsible for ensuring that everyone who is eligible is invited personally. So it's a face-to-face, patients-to-physician relation. It's not only national authority and patients and people. Here it's doctor and patient. They're also responsible for encouraging their own staff to be vaccinated and putting the procedure in place to do this. And so they have some flyers to open the campaign. They have to plan the campaign. They have an active role, a proactive role in the plan. And this plan is something which is dynamic. And we are waiting for 2018, the improvement and adaptation of this plan. So a program, holistic program with an adaptation from 1 year to 1 year because we have the feedback of the precedent year. What about France? Several years ago, France was at the same level of vaccine uptake for the 65 plus. We will see what it's today, what are today the percentage of vaccine uptake. The objective is to give free vaccine for the at-risk population, and it's based on the voucher the patient the people receive at home. Also, the objective is to give confidence back in vaccination, back. It means that people in France are no more so confident. And also, we needed simplification for flu shot because you have the voucher, you have to go to the pharmacist, you go back to the physician that do the shot, or maybe the nurse now. Some flyers are distributed or are in the clinics. And what is the results of the voucher distribution? 2008-9, 2014-15, not the same group that did the survey, but the same methodology, the same design. For the at-risk population, whatever the age is, 66% received the voucher, and 2 years after, 68%. So no differences. For the 65 plus, the same features. And for the people less than 65, you can see that only 38 and 46% of them received the voucher. What are the results? I have shown you there was no difference in the voucher delivery between 2008-9 to 2014. But we have a clear decrease here in the vaccine uptake in the population 65 plus. No real change here. It was rather low. And if we look at the different ages, I probably think that the 65, 69 don't really think they are old, so they are not vaccinated. It starts after 70 and 75 plus. But anyway, we have the same drop after this period of time. Remind you, pandemic. And in France, pandemic was the reason of a big mess, very low uptake, and discredibilization of the vaccine in the population. So what is happening in France? We have a decrease, no modification in the funding. We have the same level of voucher distribution. The GP are always the same. We had the nurse to give the vaccine, if possible. And there is no difference in the national plan announcement. But the France, people know that we are the first, we are later in the skepticism. And first time, we are the first in the class for that. And if we look at different reasons to be skepticism, to have some hesitancy with regard to the vaccine, in this survey, they look at, and they have some question. Vaccines are important for children to have. I compare France and UK. And you can see that there are already some differences. We are not at the same level to say, yes, it's important for the infants. Are the vaccines safe? Yes, they are in the UK. Not so much in France. Overall, I think vaccines are effective. Yes, in those countries, not so much in France. For the religious belief, no problem. Doesn't worry. We don't mind about that. So probably, and it's something which is very important, to give feedback on the effectiveness as fast as possible, which is more and more done every year. And we know that during the current season, the vaccine seems or not to be effective at this time. So my conclusion is that 8 years after the European Council objective are not fulfilled, with a still very low, or in some countries high, vaccine coverage rate. There are national plans and structures to improve the vaccination. Everything is in place, indeed. We have to cope with different healthcare systems and also consider different histories in these countries. European is not unified, if I can say. We have different histories with regard to the healthcare system, et cetera, et cetera. So the answer can be the same for each country. And naturally, we need a holistic vision. In this Parliament magazine, you can see here, 2015, it's a call for the EU member states to take action on vaccine hesitancy 2 years ago. And more recently, success of vaccination program is based on citizens' trust in safety of vaccines. So the politics are aware today in Europe of the problem. And also some specialists do some meeting and papers, and it's here national adult immunization plan to reinforce, to strengthen the adult immunization through a coordinated action. We have to be coordinated. So we have to improve the access, we have to increase community demand, we have to foster innovation. And another one made here in Italy, and the future of immunization policy in Italy and in the European Union. And you can see here you again have a global view. We have a lot of impact, a lot of possibilities to act on a better vaccine coverage. So it's a lifelong approach. I would say an intergenerational approach. When you vaccine a baby, you have an impact on the grandfather and reversal. When you vaccine a young lady, it's for her in 30 years later that will not have a cancer, uterine cancer. So everything is, it's not only, it's a cycle vision, not a longitudinal vision. I think we need to progress in this idea. And finally, I want to wish you for attention. Thank you.
Garau, Spain. Thank you for your nice presentation. I have a question concerning the definition of the target population. In most European countries, we use the number of risk factors well known to us and age as defined by 60 years or 65 years of age or above. However, in the US, they take a very different approach. They think that the whole population should be vaccinated. And in fact, vaccination is promoted in children when they are 6 months old or older. And the vaccine uptake, the last surveillance shows that at least 60% of children in the US had been vaccinated yearly for seasonal influenza. I think that this makes a lot of sense because influenza is primarily a childhood disease. And this, in theory at least, should have a very positive impact in the adult population. Can you comment on that and tell us why we Europeans don't like to follow this approach?
I think it's for me more common than a question because I cannot answer this question. I just can't agree on the fact in Japan it has been also shown that if you vaccine the youngest you have an impact on the elderly, and they stopped that a lot of years ago. I think the problem with flu is that you have a shot every year. And people are reluctant to have their children vaccinated every year. I think it's one of the reasons. The second one is, yes, is it important this disease or not? And I think that in my country, it's not appreciated that the flu is at risk for the youngest. There is no real data to say, yeah, we have data, but today it's not in our mind to understand that. So it's not only a vaccination to lower the reservoir of the virus in the population, but also an impact for the youngest. So we have to work on that and to say, it's not only, you not only have to vaccine the baby for the parents or grandparents, who have to vaccine babies for themselves. So we have to change our mind. I agree with that. I can't say something else.
Mel Cohn from MSD in the US. Jacques, thank you. Very interesting talk. And your question, I wanted to say, I was the health officer in Oregon during the H1N1 pandemic. And one of the things that we learned very clearly from our experience there was that when the school kids stayed home during vacation times, the epidemic stopped. And so I think this emphasizes the value of vaccinating children to prevent a much larger phenomenon. But the question I wanted to ask you, I was really struck by the diversity of recommendations, even around flu vaccine, which, you know, as vaccines go, this is about as non-controversial as we could get, one might think. And yet, across Europe, there's this huge diversity of recommendations. I'm not talking about the implementation part of it and the healthcare system part of it. I'm talking about the end goal. So I guess I'm wondering, should Europe somehow be trying to move towards some harmonization of these recommendations, number one? And if you believe that that's true, what's the forum or mechanism by which that might happen? And specifically, since we're at a meeting here of EICA and EU GMS, what role might these organizations play? Do you have a position on this and ongoing activity on this?
I think we can also take the example of pneumococcal vaccine. A very old paper performed by Peabody have shown that with the same data. In Sweden, 13 at-risk conditions were considered to give the opportunity of the patient to receive the vaccine. In other countries, only 2. It's the same story. And for the age, the same story. Some of them 50, 55, etc., etc. So we have to harmonize. But to harmonize, maybe we have, I think that the role of this group is to say we have to stop to be different because we have the same population, we have the same gross product, nevertheless. And we have to share and to decide something. It's no more time to say, yes, we can do that. Why I finish with the Parliament magazine? It's because the politics have to understand that and to say, okay, we have to put something. Well, you know, in France, I just read recently a paper on the preventive medicine and the curative medicine. It was a paper in the Lancet 2 years ago. We are the 5th rank for the curative, for the care. We are at the 50th rank for the prevention, 2.5% only of the national product. And in other countries, 3.5. So if you reduce the possibility to pay, you reduce the population to protect. So it's also the thing we have to look at. So the problem, I think, it's very high level. So we we have to give the information to the politics, I think.
Thank you, Mr. Chairman. Thank you for your nice presentation. My question is, I am from France, so my question is about hesitancy, of course, in France. And I am a little stressed by the new epidemic of the last 2 or 3 years, not with H1N1, but with H3N2. And we saw the last week the same problems in Africa and Senegal. They have the same problem of 2 peaks of epidemics with H1N1 and after H3N2. And H3N2 is more severe, seems to me. So there is a problem for the GPs first to speak about effectiveness to his patients, persons. It's not so easy. It is not so easy to have the good. It is not measles, you see. It is a variable influenza epidemic and variable effectiveness, perhaps, of vaccine, the first thing. And the big problem is to speak about the failures. Newspapers this last year have written about the failures for H3 and 2. What do you think about that?
First thing, yes, H3 is much more aggressive, and the association between H3 and pneumococcus seems to be clear. So that's a fact. The big problem is about the low efficacy or effectiveness of the vaccine and changing from 1 year to another one. And you are at the middle of the season and you hear, oh, this year it's only 17% efficacy of the vaccine. So you did all this job just for 17%. So the problem is we have to say, yes, 17 or 25, it's not so bad if we look at the public health system. When you are in the emergency department, if we can reduce from 2 to 3% the admission, it's a good result because we really know that we have the bed, there are no bed to take these patients, to care them. So if we can reduce. And probably like, say, Jacques Gaillat, if we can vaccine the infants, we can have better action. So, and we know that the vaccine is much more effective in the youngest. But it's difficult to say, yes, you have to vaccine, but there are failures. We have to be honest and to say, yes, 1 year it's good, another one. But in front of that, there is no, it's safe. There is no danger to be vaccinated every year. We naturally know that from 1 year to another one, maybe the efficacy is not so well. Okay. But at the end, it's better to be vaccinated every year than not vaccinated.
Timo Stamberg, Helsinki. Thank you very much. It was very thought-provoking on a very common thing. Thank you very much. I would like to ask your opinion about compulsory vaccination, because I think in the United States there are some health systems where it's required that you cannot get a job without vaccination. And also in this country there is now with this measles epidemic. So what's your opinion about compulsory? It's the whole thing.
I think we will wait Gaetan's Gavazzi's presentation, because it's about healthcare workers' vaccination. I will take part of the discussion, naturally.
I have a general comment I would like to make in this respect. When I see in your presentation the key role that the general practitioner should have, I have some concerns in the sense that based on my experience during the pandemic, the last one, of course, I mean, I have the strong feeling, and sometimes I'm convinced, that the average general practitioner is totally ignorant of vaccines and vaccination. This in Italy, for example, but I doubt that the average would change significantly in some countries, probably France. My daughter lives in Paris, and believe me, her general practitioner, okay, I advise her to change. So this is my comment. Who educates the educator? Who informs those people who have to inform? At our universities, I'm an MD, I never received any formal course on vaccines, for example. And I doubt that things have changed significantly. So this is something that probably we should take into account when we move from the vaccines, and we have to inform the user about the plus and the minuses also. 50% of efficacy, why not? I mean, why not to use a good, not to use the good waiting for the better? This would be crazy, I mean. So this is the point I would like to stress. I mean, what are we doing to fill the gap of the education of the general practitioner who works in the field?
I agree. In France, during their studies, they have only 3.5 hours spent on vaccination knowledge, only 3 hours. And when we see that their role is so important in the prevention, it's difficult to understand. Yes, there is an influence about this, because yes, they have to do that, but they don't really know, and they want to have something which is static. Vaccine is that, but when I do some education with the GPs, I say it's a dynamic process. When you look at the streptococcal vaccination, it changed a lot between after the beginning of VPC 7. It's totally changed in the serotypes distribution. And they have to understand that today we have to go and run to follow the evolution of Streptococcus pneumonia. And I think their problem is the relation to patients. We don't speak today with the social network, but social network have a big impact on the role of the physician. When you look in the press, in France again, 200 papers in big journals, in big newspapers, 45 were for the vaccination, and all the rest were against. It was wrong. So they have to fight. Today they say have to fight with the parent to give the hepatitis B vaccine. And in France, we also have the problem with recommendation or mandatory vaccine. In the same syringe, we have 3 of them. Say, I just want the mandatory vaccine. No, it's very difficult for them to have a good message. Very, very difficult.